button. ठीक है, ठीक है, ठीक है. Let me check on YouTube also, है ना? I've opened already. Just wait. Yeah, yeah, it's there. It's there. So, hi everyone. So, welcome to the session of acute cholecystitis. The topic for the today's discussion is acute cholecystitis. And let me introduce to myself. I am your educator for the subject of surgery. My name is Dr. Saurabh-Dixit, and I'm a consultant laparoscopic surgeon in New Delhi. So let me just this is the topic for the discussion today: acute cholecystitis, and we will try to have a complete clinical approach for this topic. And please, students, note down that these are the subscriptions that these are available for us. Okay, so we have a test and discussion series. We have a test and discussion. We have many new batches coming for. We have revision batch which has started on 18th of Jan. We have a batch for INI CET, and we have batch for FMG. We have a batch for the next 2022 also. Yes, if you join, yes, please do use the code Dr. Dixit, and let us start with the discussion for the today's topic. Yes. Now, when we talk about acute cholecystitis is a day-to-day problem for us. Acute cholecystitis. Acute cholecystitis. Now, the first and the most important thing is, yes, how to diagnose this acute cholecystitis. How to diagnose this acute cholecystitis, because we all are often confused between signs and symptoms and what is a biliary colic when we will call it acute cholecystitis. So these are very important things that we should be keeping in our mind. Let us talk about the diagnostic criteria for acute cholecystitis. So what are these patients classically presenting to us with? If you talk about the clinical presentation, students, if you talk about the clinical presentation, yes, the classical clinical presentation is the pain in abdomen. Yeah, the pain in abdomen. The classical clinical presentation is the pain in abdomen. Now, if you talk about the pain in abdomen, the classical localization or the classical pattern of the pain is the right upper quadrant pain. This is the location of the pain, right upper quadrant pain. Yes. And along with this, the patient has what often complain of what? Vomiting. Vomiting. Yes. So pain in abdomen plus minus nausea or vomiting. Intractable dyspepsia also. These patients have plus intractable dyspepsia. Intractable dyspepsia also. This is the classical presentation of these patients. Now, this intractable dyspepsia or pain in abdomen could be also, and even vomiting also, could be a feature of acute gastritis also. And there was a lot of confusion as what is acute cholecystitis, what is not. So we all came to a joint consensus, and where this consensus happened in Tokyo. So there is a guideline which is known as Tokyo guidelines. Tokyo guideline. So Tokyo guideline of 2013 and 2018 then. So two conferences have been held. One was in 2013 and one was in 2018. And the aim of these conferences were to let people understand the concept of acute cholecystitis and cholangitis. Because what happens, majority of the consultants don't know. A delay in the management of acute cholecystitis and cholangitis can cost even life of the patient also. So what is cholecystitis? How to manage them? What is the diagnostic criteria? We don't have to rush for those features like if here we have this, on here we, on palpation here if you have tenderness, blah blah. We have a set principle of management. So let us talk about the diagnostic criteria. Let us talk about the diagnostic criteria. If we talk about Tokyo guidelines, first of all, we should know what it is for. So Tokyo guidelines is a guideline for diagnosis. So diagnostic plus management criteria. Diagnostic plus management criteria for acute cholecystitis and cholangitis. So for acute cholecystitis and cholangitis. Now, what I am going to teach you today is a brief but yes important concept of acute cholecystitis. Now let us see when will you call it to be what acute cholecystitis. There it is based upon two factors. One is the radiological factors and one are the clinical signs and symptoms. So let us see how we diagnose. So let us talk about the diagnostic criteria. It's very easy. It's very easy. So we have local features, and this is designated as column A. We have local features, this is designated as column A. Then we have systemic features. We have systemic features, and this is designated as column B. And then the third column is the radiological features, which we will see at the end. So what are the local features? The first classical local feature is right upper quadrant pain. Right upper quadrant pain is very important. So right upper quadrant pain. Right upper quadrant pain. This is very important. If there is right upper quadrant pain, yes, it is taken. What is the another one? What is the another one? Yes, a Murphy's sign. A Murphy's sign. A positive Murphy's sign. What do you mean by Murphy's sign? A positive Murphy's sign. Tenderness at the right upper quadrant such that the patient has or patient suffers of what? Inspiratory jerk. So what is Murphy's sign? When you press the right upper quadrant of a patient with acute cholecystitis, actually the gallbladder touches the visceral or touches the parietal peritoneum. Even the diaphragm is irritated and phrenic nerve is also irritated. Yes. So whenever you press it here, there is acute what? Inspiratory jerk. It's like so this is classical Murphy's sign. This is classical Murphy's sign. What is Murphy's sign? It's an inspiratory jerk. It's an inspiratory jerk which is seen on deep tenderness or deep palpation at the right upper quadrant sign. This can be elicited clinically even by the radiologist also, and that is what is known as probe tenderness. That is what is known as probe tenderness. Let us talk about the systemic features. Let us talk about the systemic features. The complaint of fever. A complaint of fever. Yes, complaint of fever is also taken into. Second is elevated WBC count. Elevated WBC count. Yes, elevated WBC count. Can you people tell me what is a marker of inflammation? What is a common marker of inflammation that we use? Come on, tell me, what is a common marker of inflammation that we use? Yes, we use something from C. What is that? C reactive protein, CRP. Yes. So elevated C reactive protein. So fever, WBC count, elevated C reactive protein. Very good Naveen, very good Gaurav, very good. Yes, Hemant, everyone is answering. It's very good to see all of you interacting. So bache, this is A, this is B. Then we will see what is C. If you talk about C, this is equal to the radiological features. This is equal to radiological features. Radiological features. Yes. What are the radiological features? Presence of stone. Presence of stone. Yes. Second is yes, increase wall thickness. So increase wall thickness. Can you people tell me what is this increase criteria of wall thickness? How much increased thickness is considered significant? Come on, tell me. Tell me, students. What thickness is considered to be significant? More than what mm? More than what mm? Tell me. More than 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. What mm? Tell me. You people will tell me. Pericholecystic fluid, collection of fluid. Pericholecystic. No Naveen, no Gaurav, it's not this. Yes, it's 5 mm. 5 mm. It's not 3 mm, bacho. More than 5 mm is considered significant. So wall thickness more than 5 mm is considered significant. Is that clear? More than 5 mm. Again, presence of biliary sludge. Presence of biliary sludge. Presence of biliary sludge. Yes or no? Yes. Then fifth. Yes. So wall thickness, stone, pericholecystic fluid, biliary sludge, or probe tenderness. Probe tenderness. These are the classical features. Now let us see how we interpret them. Yes, let us see how we interpret them. Now, anyone in A plus anyone in B. If you have any one local feature and complementing to it, you have any one systemic feature. This is considered to be what? Suspected acute cholecystitis. Suspected acute cholecystitis. So patient presenting to you with fever with right upper quadrant, you can say right upper quadrant pain, you can say this may be acute cholecystitis. Then any one in A or B, any one in A or B, yes or no, plus any one or more in C, this is confirmed acute cholecystitis. Confirmed acute cholecystitis. Is that clear or no? So can you understand the importance of radiology? And who will tell me what is the radiological assessment tool of choice? Tell me, what is the radiological assessment tool of choice for gallstones? Can you tell me what is the radiological assessment tool? Yes, very good. Come on, tell me. Yes, great. Everyone is answering right. So radiology of choice, radiology, and that is equal to investigation of choice. Everyone is very good students, very good. It is USG abdomen. Now you people will answer. So this is a rapid fire. Don't consider that I am an educator and you are students. This is a surgery CME. When you are studying the subject, you should have that aura of what surgical, you can say that surgical aura. Imagine all of us are in a conference room or in an operation theater and we are talking. I am S1, you people are S2, S3, like this. Yeah. So we people will share the thoughts. Yes or no? Now you will tell me what to do if USG is not available or USG is inconclusive. Yes. So what are the other sensitive investigation? What are the other investigations which can be done? Other investigation in case USG is inconclusive. If USG is inconclusive, what are the other investigation that we can go for? No students, Aman, it's not X-ray, because majority of these stones are radiolucent. Majority of the gallstones are radiolucent, so X-rays are not going to work. Come on. MRCP, no. CT scan, no, not at all. The reason is CT scan, generally the stones are less than 1 centimeter. The CT slices, they often miss off. So this is not. Come on. There is something from, there is a scintigraphy. There is a scintigraphy. Can you tell me what is that scintigraphy? MRCP is for CBD pathologies, to study the biliary tree. We use that. There is something. Yes, very good, Aishwarya. Very good, students. So it's HIDA scan. HIDA scan is in fact the most sensitive investigation. Do you know? We have HIDA scan. HIDA scan. Do you know? Yes. HIDA scan is the most sensitive investigation. Most sensitive investigation for available. Most sensitive investigation available. No, not fibroscan. Fibroscan is not. Fibroscan is to estimate the what? Liver. Yes, a cirrhotic liver. We want to evaluate the liver. Now let me tell you, this technetium 99 base dye. What is the function? The reticuloendothelial. The endothelial cells of liver. So reticuloendothelial cells, they are sensitive for HIDA. They are sensitive for HIDA. So they will take up the HIDA. Yes or no? And this HIDA, this will be secreted in what? Bile. Therefore, this agent will be secreted in bile. Normally, after injection, it takes 30 minutes for HIDA to cover up the biliary tree. बच्चे after 30 minutes of injection, the image should be like this. The image should be like this. Yes or no? The image should be like this. So can you see? You can trace. If you want. You can say, no, this is the biliary tree that you are seeing. Yes or no? And this is what is gallbladder. This is how you trace. Now try to understand non-visualization of gallbladder after 30 minutes. Yes or no? This is equal to, yes, acute cholecystitis. Is that clear to everyone? Is that clear, students? Acute cholecystitis, how we interpret? Yes, how we interpret this? Yes, acute cholecystitis. Normally, after 30 minutes, you can see the gallbladder. After 1 hour, बच्चे, you can see HIDA at the level of bowel. Even at the level of bowel, you can see HIDA. Is that clear to everyone or no? Now, have you heard about a condition, GB dyskinesia? Have you heard about a condition, gallbladder dyskinesia? Gallbladder dyskinesia. What do you mean by gallbladder dyskinesia? Yeah. What is dyskinesia? Non-functional. Yes or no? Non-functional gallbladder. And why non-functional gallbladder? Because of the defect at the level of sphincter of Lutgens. Yes. So if there is defect at this level, yes, there is gallbladder dyskinesia. So when you are going for HIDA, on HIDA after 30 minutes, a faintly visible gallbladder. What is this known as? Yes, this is indicative of that gallbladder is working, but is dyskinesia. However, take my words. Is that concept clear to you? However, take my words. Merely HIDA scan, going for HIDA scan, this is not conclusive of gallbladder dyskinesia. You have to understand that gallbladder dyskinesia is an answer of exclusion. Gallbladder dyskinesia is an answer of exclusion. Is that clear to everyone or no? Gallbladder dyskinesia is answer of exclusion. Everyone, is that clear? Apart from this, there is one more investigation which is very sensitive. Do you know? Endoscopic ultrasound. Yes, ultrasound. That is EUS. EUS is also a very sensitive investigation for hepatobiliary tree. Sensitive for bile ducts, gallbladder and pancreas. Is this clear or no? But see, we don't use it in case of acute cholecystitis or for gallbladder pathologies. Basically, this is useful in cases where we want to evaluate the cholangio section, that the gallbladder, that the biliary tree. Yes or no? The advantage is that you can attach a brush biopsy probe and take a biopsy also. Generally, we don't go for true cuts. We don't go for percutaneous biopsy because we fear that a cancer will be disseminated. So that is the reason now EUS guided biopsies or FNAs, they are gaining the popularity. Is this clear to everyone, students? Is this clear to everyone till here? So let us move forward now and let us go on the severity of gallbladders or severity of acute cholecystitis. So before that, you should know that acute cholecystitis is of two types. acute cholecystitis is of two types. What are the two types of acute cholecystitis? Can you tell me what are the two types of acute cholecystitis? Many of you know that yes, it is acute calculus cholecystitis. Acute calculus. This is the most common version or no? No, laymen have a language and they have a thought procedure that if there is a stone, then only they will get what? Infected in the gallbladder. And if there is no stone, then it could be anything, but it couldn't be what? Acute cholecystitis. But this is not right because there is a very important term which is known as acute acalculous cholecystitis. Now, what happens? Many of the people are not knowing about acalculous cholecystitis. Now, layman or a patient has a notion that there has to be a stone in gallbladder. You operate, then patient asks after surgery, "Sir, you have not taken out the stone." Then you say there was no stone. Then patient starts abusing you, saying that, "Oh my God, this doctor is a traitor. He's a cheat. Yes, he has misguided me. There was no stone, and then also he has operated." And if you're not confident with this criteria, or if you're not confident with the concept of acalculous cholecystitis, you will not be able to defend. So later, definitely you will search for evidences and say, no, देखो ये भी होता है, वो भी होता है. But you should be confident. Yo, this is acalculous cholecystitis. Do you know acalculous cholecystitis? What are the causes of acalculous cholecystitis? Can you tell me what are the causes for acalculous cholecystitis? Anyone? Yes, come on, tell me. Very common is what? Yes, bedridden patients. Bedridden patients. Yes, bedridden status. Apart from that, what else? What else? Infection or sepsis. Yes. What else? What else? देखो, sludge can be considered as a calculus one also, but yes, since sludge is a precursor stage, I may consider it. Then yes, parasites. Apart from that, trauma. Yes, trauma. Apart from that, yes, post surgery. Very good. Post surgery. Apart from that, have you seen my video on parenteral nutrition? In that, I have already told about TPN. TPN, total parenteral nutrition. What is the reason behind acalculous cholecystitis? Answer is yes. Answer is, what is the reason behind? Yes, cholestasis. Cholestasis is the reason. Cholestasis is the concept behind acute acalculous cholecystitis. Now I'll share one report also. Today in morning I admitted one patient. Yes, and luckily I have got that report also, that patient's report. Try to see this report. I've admitted this patient in hospital, and he is 50-year-old male with complaint of what? With complaint of pain in abdomen. Pain in abdomen. And can you see his gallbladder? This patient has been referred to me by a local practitioner. And just see, what is this? Patient is having pain in abdomen, right upper quadrant. Yes or no? So right upper quadrant pain in abdomen. Let us see what it could be. Yeah, what it could be. Let us see. Yes, just see. So pain in abdomen with gallbladder wall appears edematous. Yes or no? So 9.2 mm thickness. 9.2 mm thickness. Yes. Pericholecystic collection is also there. Pericholecystic collection around the gallbladder. The collection is also there. Yes or no? CBD is absolutely normal. So what is this? Tell me, what is the diagnosis? Patient presents to you with right upper quadrant pain. Only this. Right upper quadrant pain. Ultrasound was done. This is the diagnosis. Can you tell me what is the diagnosis? Everyone. Yes, this is a case of acute cholecystitis. Yes or no? What type of acute cholecystitis? Boss, this is acute acalculous cholecystitis. Acute acalculous cholecystitis. Is it clear to everyone? Is this clear? So you should be able to understand the basic concept. Basic concept is very simple. Very simple. Now, based upon the Tokyo guidelines of 2013 and 2018, we have further defined acute cholecystitis of three types. What are they? Mild, yes, moderate, and severe. Mild, moderate, and severe. Mild, moderate and severe. Let us see what they are. Mild, this is acute cholecystitis in apparently healthy individual. In apparently healthy individual. So acute cholecystitis in apparently healthy individual. Yes or no? Yes. Apparently healthy individual. Everything is okay. The patient presented to you with pain and you went for ultrasound and there is a stone detected. This is what. What is moderate? What is moderate? This is very important. Now, duration of symptoms. Symptoms. So this is acute cholecystitis plus any one of them. What is any one of them? Symptoms for more than 72 hours. Generally, acute cholecystitis. What is difference between a biliary colic? Biliary colic is also what you can say is also intermittent. Whenever patient eats, patient has a pain, distension of abdomen, biliary symptoms. But say the duration is only for 30 minutes to maybe 1 hour. Acute cholecystitis generally persists for 6 hours, 12 hours, maybe 24 hours. Very seldom that it may continue beyond. And if it continues beyond, yes, this is not a mild form. It is either a moderate or it is going to convert itself into a severe form. So symptom duration more than what, 72 hours. Yes. Or you can say WBC count grossly elevated more than 18,000. Yes, more than 18,000. Or a palpable tender mass. What is that known as? Palpable tender gallbladder. Palpable non-tender according to Courvoisier's is seldom due to stones, but palpable tender gallbladder is due to stone. Is that clear or no? Yes. So let us talk about palpable tender gallbladder. Palpable tender gallbladder. Yes, tell me. Palpable tender gallbladder. Come on. Come on. What is that? Something from M and something from E. Mucocele, boss. Mucocele. Mucocele of the gallbladder. Mucocele of the gallbladder. This is mucocele. Yes. Or if the infection goes, what is this known as? Come on. What is this known as? Empyema gallbladder. Empyema gallbladder. Empyema, not emphysema. Empyema gallbladder. Yes. Or signs of necrotizing lesions, or others. What are the others which could be included in this? Yes, a pericholecystic abscess. A pericholecystic abscess. Pericholecystic abscess. Point number 1. Students, emphysematous gallbladder. Emphysematous. Empyema is different. Emphysematous gallbladder. Can you tell me emphysematous gallbladder? What is the investigation of choice if you see a gas? If you see gas around the gallbladder, what is the investigation of choice? Tell me. But say to confirm this, CCT is the investigation of choice. CCT. Yes. Necrotizing gallbladder or gangrenous gallbladder. So if you have any one of them, it is considered to be a moderate. But say what is a severe acute cholecystitis? This is acute cholecystitis with no Lakshmi, it's not USG, but it's CCT. Acute cholecystitis. Come on, I want this answer from you. What is severe? What will happen now? Patient will undergo what failure? Organ failure. Patient will undergo organ failure. So this is what is severe. Patient will undergo organ failure, and this is what is a severe variety. Is that clear to everyone or no? Is that clear to everyone? Yes. Let us move forward now. Let us quickly move forward and go to the management. Yes. Now management has been updated. So 2013, which you are reading in Bailey and Love, is not the same now as 2018. Some things have changed, and that is in the management of what? Moderate and severe. So let us quickly. Students, are you enjoying this topic or no? I'll make it more interesting. Don't worry. I'll make it more interesting. Yeah. Let us talk about this. Management. If it is mild, if it is moderate, if it is severe, the first step is same. What is the first step? Yes, start with antibiotics plus supportive care. plus supportive care. Supportive care. Start with antibiotics and supportive care. And after that, yes, the plan is plan plan emergency lap cholecystectomy. Emergency lap cholecystectomy. There is no indication of open cholecystectomy now for the mild. It is lap cholecystectomy, which is ideal. You don't know that is a different thing. It's emergency lap cholecystectomy. Yes. Duration part, earlier we used to say 5 to 7 days and this and that. Now it is said, it is jolly well said, कि if you are confident laparoscopic surgeon, you can do it at any time. So at centers where laparoscopic surgeries are practiced, you can do on 21st day also, 22nd day, 23rd day. I do lap cholecystectomy even within 2 hours and after 20 days also. So if you have all those facilities, if you have advanced instruments like harmonic scalpel society, why do fear? Why to fear? Don't fear about adhesions. You can easily do adhesiolysis. So emergency lap cholecystectomy is what is done. Next is moderate. Now here the concept of that window phase is still there. Yes, moderate. Now if you talk about moderate acute cholecystitis, then you need to start with what? Start with antibiotics plus supportive care. Antibiotics plus supportive care. And the next principle is, yes, duration of the symptoms. Yes, duration of the symptoms. Duration of symptoms. If it is less than equal to 7 days, if it is less than equal to 7 days, you need to see the patient status. Yes, you need to see the patient status. Yes, if you talk about the patient status, yes, patient's status, yes, you need to see it is improving. It is improving. If it is improving, you need to go for emergency lap cholecystectomy. Emergency lap cholecystectomy. Emergency lap cholecystectomy. Is this clear or no? Yes. If it is constant, or worsening, if it is constant and worsening, now comes the role of advanced center versus a normal center. Yes or no? Advanced center and a normal center. If there is constant status or it is worsening, now check whether either you can go for emergency lap cholecystectomy. Let me tell you, the only way to get rid of cholecystitis is get rid of gallbladder. Is that clear? There is no guarantee that if you continue the conservative management for next 4 to 6 weeks, the patient will not be relieved of pain. So boss, if you are in an advanced center, you have to go for emergency laparoscopic cholecystectomy. Is that clear to everyone? Emergency lap cholecystectomy in advanced center. Is that clear? Yes. Or conservative management. For 4 to 6 weeks. And then plan interval, or you can say interval lap cholecystectomy. Is that clear? Try to understand. Now, today, doing an open cholecystectomy is not a taboo. It's not right. It's not right to say that a surgeon is not competent if he has done open cholecystectomy. It is said that be wise. Choose the patient's integrity to your ego. Don't be egoistic. If you think that you cannot handle this case, refer the patient to higher center. Don't be egoistic. Gallbladder, if it is gallbladder, I will do this gallbladder. No, because your ego can damage a patient's life. So whenever you have a doubt that you cannot handle, refer the patient. Whenever you are in doubt that you can do this surgery in open, do that. But let me tell you, a surgery which is tough in laparoscopy is twice tough in open surgery. Try to understand. You are getting magnified view. And in open surgery, you get a compromised view. Most of the time, you're not even able to see the callots properly. We are doing a dissection. They're going deep inside and we are doing the dissection. Is that clear or no? Something which is tough in laparoscopy is twice tough in open surgery. Try to understand. But now the management of severe. Now the management of severe acute cholecystitis, this has actually changed. This has actually changed now. Now severe acute cholecystitis is a cholecystitis with organ failure. Yes, organ failure. Now here you have to check about what organs are failing. Yes, if a patient is having, yes, hepatic failure, if a patient is having hepatic failure, how do you come to know about hepatic failure? Enzymes are raised. Or if the patient is having what? Neurological features, yes, neurological manifestations, yes, encephalopathy, like encephalopathy, encephalopathy, yes. What else? Encephalopathy. Or if the patient is having respiratory failures, let's say these are the patients where surgery is absolutely contraindicated, and hence you need to take out that septic bile out of that body. So in these cases, if yes, the answer is yes, you go for USG guided bile drainage. And what is that known as? Cholecystostomy. Cholecystostomy. So USG guided cholecystostomy. So what is that cholecystostomy all about? Yes, it is actually the percutaneous drainage of the infected bile. So when bile is out, the symptoms will subside and you get time to expedite the patient recovery and give the patient support. You do, after this, you send the bile for culture, and continue conservative support. Is that clear to everyone or no? You must have known this complication. But again, nowadays, what is interesting, even for severe acute cholecystitis, surgery is permissible. Yes, for features like cardiovascular compromise. If there is a cardiovascular failure, this is a failure which might improve with the time. So here, when you have a cardiovascular failure, always talk about the performance status. You must have heard of a Karnofsky score also. Yes, there are many performance status. So performance status, you talk about the performance status. Students, all those things which are given in books, the majority of the books are not explaining the concept of acute cholecystitis. So based upon the performance status poor, bache, you follow this concept. If the performance status is good, yes, go for lap or open. Yes, cholecystectomy, and that too emergency lap or open cholecystectomy, and that too in the advanced center. So this is the basic concept of the acute cholecystitis. Tell me, is this part clear? So now I will highlight how we go for laparoscopic cholecystectomy. Within 5 minutes, I'll explain each and every concept of that. Yes, is this basic concept of approach to a patient of cholecystitis clear or no? Now, if you talk about the management or the treatment, that is a laparoscopic cholecystectomy. Yes. Today, gone are the days when we used to say surgery, laparoscopic cholecystectomy is contraindicated for this and that and that. Today, the only contraindication for gallbladder laparoscopic cholecystectomy is intolerance to anesthesia. Intolerance to anesthesia. Earlier, we used to say intolerance to general anesthesia. Now there is a case study. Which has given that spinal anesthesia is equal to GA for lap cholecystectomy. Do you know, in last 10 months after this study came out, I have not done any laparoscopic procedure in GA except for total laparoscopic hysterectomy and fundoplications or bariatric surgeries. All cholecystectomy, all appendicectomy I'm doing in spinal with bupivacaine. What is the problem with spinal? There is diaphragmatic irritation, and hence the shoulder tip pain is a very common thing. Shoulder tip pain. So what I do? I take bupivacaine and spray it over the diaphragm, and that is okay. The second problem with spinal anesthesia is abdominal movements, which might hinder. So if you are expert in laparoscopic cholecystectomy, spinal is now the choice. The advantages, there are two advantages: speedy recovery, cost effective, and patient effective, lesser comorbidity. Is that clear? Lesser risk. GA is associated with more risk. So the only contraindication is intolerance to anesthesia. Earlier, even CAGB was considered a contraindication. Today we are doing majority of the resections in laparoscopy. We have endo bag, we deliver it out. So no point of port site contamination. Is that clear? No, gone are all the days. So today lap cholecystectomy is the gold standard. Now if you talk about the procedure, the first step in this is creation of a pneumoperitoneum. The creation of a pneumoperitoneum. We are just about to complete this. So creation of a pneumoperitoneum. Now pneumoperitoneum can be created by two ways. Yes, what are the two ways? Either with a varice, or this is my favorite, or you can do via what? Open technique. Open, or you can say semi-open. Varice is considered as the safest. Why? Because with the varice needle, the abdominal distension is slow and gradual. With the slow distension, the stretching of the abdomen is not seen. The sudden stretching of abdomen causes what? Vagal hyperstimulation. And that is the reason you have what? Sinus bradycardia. Again, many a times, the overconfidence of a surgeon, you just poke the trocar what in a flattened abdomen, and you enter inside a viscera, or maybe a what? Maybe a you can say a bowel, a hollow or solid viscera, or maybe aorta also. So these are the complications which are ideally avoided. And once you have done the pneumoperitoneum, you establish the ports. Yes, you establish the ports. We follow the baseball diamond concept. Don't mug up the port positioning of these patients. Don't mug up. The ports are positioned like if this is the abdomen, this is the target. Always remember, draw two arcs. One should be 12 centimeter and one should be 18 centimeter and one should be 24 centimeter. Your camera port should always be in between 18 to 24. Use your common sense, because the scope is 36. Use that concept of physics. If you go too close to the target, the image will be magnified. If you go too far, f and 2, a focal length, everything. So the scope is 36. So we have to keep it somewhere between 18 to 24. So always your camera can be anywhere along this point, anywhere, wherever you are comfortable. And then your operating ports. So camera port, if you talk about the target, the camera port should be in between the 18 to 24 centimeter mark. Now, what is the advantage of this 18 to 24 centimeter concept? The advantage of this 18 to 24 centimeter concept is majority of the time this falls at the level of umbilicus, and that is why umbilicus is the most favorable. Umbilicus is the most favorable site for insertion of what? The telescope. Then the two ports should be such. These are the operating ports. The operating ports should be such that the maximum angle made by them is 90 degree. So if this is the target, and this is the 18 centimeter mark, this is the 24 centimeter mark. Here, suppose you have put the camera. So your operating port should be on the 18 centimeter point. The 18 centimeter point, at least they should be making an angle of 90, not more than 90. Because if you make angle more than 90, try to understand. If it is 90, you are comfortably operating. If it is too close, they will become parallel. If you are like this, what will happen? You will not be able to operate. You will have shoulder tip bursitis. All these problems will happen. So in this case, the ports are present in the epigastric region. This is the epigastric port. This is a 10 mm port. This is also a 10 mm port. This is a right subcostal port. And this is a right iliac fossa port. The right iliac fossa port and right subcostal, they are 5 mm ports. Why they are 5 mm ports? Because they don't have to extract anything. The operating instrument is sufficient for 5 mm, and that is why 5 mm ports are used here. This is the the right subcostal and epigastric port are the main operating port. They are the main operating port. They are the main operating port. And this is right iliac fossa port is a traction port, is a traction port. After this, what is the next thing? You dissect the calots. You know that we need to dissect the calots. Once the calot is dissected, you put the clips on cystic artery and cystic duct and divide them, and you deliver out the sample. So now very quickly, I will show you the concept, these concepts, how we make a pneumoperitoneum, how we move forward with the things. So let me just quickly go to the, yeah, okay. Now try to understand how we do the dissection. Okay, so let me show you how we do a cholecystectomy. Let me quickly show it to you. Okay, now try to understand. This is, I am doing a dissection. I am doing a dissection of the calots. I am doing the dissection of the calots, and let me show you everything. Okay. Okay, so with a harmonic scalpel, I am doing a dissection of calots and I am removing the adhesions. Now, can you identify the structures here? Try to identify the structures here. Yes, this is your cystic duct. This is your cystic duct. This is your cystic artery. This is your cystic artery. Can you see one structure here? I'll erase this and try to see this structure. Can you see this? Can you see a structure here? Can you see a structure here? What is this? But this is cystic lymph node. Cystic lymph node. Yes, cystic lymph node. And let us move forward. Let us see how we dissect off. So can you see I am doing a bit of adhesiolysis? Yes. And now with the Maryland, I will open. Maryland is equal to your what? Maryland is equal to your artery forceps. So just see, I am opening the calots. I am opening the calots for this patient. Yes. And the calots has been beautifully opened. The calots has been beautifully opened for this. And I'll show you how we do a clipping, etc. You can see how we do a clipping also. I will show you one video. Try to see this video. The calots has been opened. The calots has been opened. And now I have put the clips. Can you see? What is a calots triangle? Try to understand. Try to see this calots triangle here. What is a calots? This is cystic duct. This is cystic artery. And this is what? Common hepatic artery. This triangle is what is known as a calots triangle. This is what is known as a calots triangle. So very quickly, I'll show you how we do, how we cut the, how we put a clip. Can you see a calots open here also in this video also? So I'll put the clip. This is a titanium clip. These are the titanium clips, LT200, LT300. I will put, always remember both the jaws should be visible and you should put it. And then I will show how we, so this is the second clip that I have put, and I will show you how we cut it also, Just see how we divide it. So I will divide the cystic duct for you. Can you see beautifully? I have divided the cystic duct. Nowadays, we have one more type of clip applicable. We have one more type of clip, that is Hem-o-lok clip. Let me tell you. Now, what is the problem with titanium clips? What is the problem with titanium clips? First of all, titanium clips that we are using, they have a risk of slippage. This is a big problem. And then, yes, cystic duct, cat eye stone formation. Cystic duct, cat eye stone formation. Cystic duct, cat eye stone formation is a second drawback, and that is why nowadays we are preferring Hem-o-lok clips. 0% chance. It's a polymer of silicon and other alloys, and it's beautiful. I have stopped using silicon. I have stopped using this clips. I'm using the Hem-o-lok clips also. Try to see this Hem-o-lok clip. Try to see. Oh, where has he gone? Yes, I will show you Hem-o-lok because these are very important. Yes. Yeah. Try to see this shape of this clip. Can you see the shape of this clip? This is a Hem-o-lok clip. This is a Hem-o-lok. Can you see the shape? If you get this in exam, you should be able to identify this is not a Liga clip. This is a Hem-o-lok clip. And try to see how we work with this. Yes, very quickly I will show it to you. So it has gone in, and just see beautifully. It will go inside, and I will show it to you. Oh, there is a lot of brightness. Yes, it has gone in. And it is locking. Yes, it is locked. It is locked inside. I will quickly show you one more clip, one more hemolock, one more hemolock. Can you see the shape of this hemolock? You have to press and go inside. We have to press and go inside and just see. Yes. Gone. 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 Yes, beautiful. And then third, I have put a titanium clip, and then now third, I have shown a titanium clip. Just see the difference. Can you see the difference? So I have put a titanium clip. This is on the specimen side. So specimen anyways has to come out, and then with a harmonic scalpel, I will divide. Don't do this. This is luxury. I am doing because I can. But harmonic scalpel should not be used for cholecystectomy at least. Cholecystectomy at least. Harmonic scalpel you should not waste the harmonic scalpel like this. But I used just because I wanted to show you. Can you see? I will cut and there will be no leakage. This is what is beauty. It cuts with a sealing effect. It cuts with a sealing effect. Beautiful. Just see. Beautiful. Gone. Gone. So this is all that we should be remembering about cholecystitis. I hope you liked the today's session. I'll be bringing many more YouTube sessions for you. Please try to understand Unacademy is the most you can say student friendly platform available today. It's not only student friendly, it's for clinicians also, for like me. I'm in my hospital, I've done a surgery and I'm doing again the surgery after this, and I'm taking the class. So what an opportunity. I can show anything to my students. I'm working happily, you people are happy. Time is the most precious thing, and this platform knows the importance of time for students and educators both. And that is why we are just wanting to give everything to our students. This is the best platform. Do join us for the courses. Do log in for the special free classes. Yes, there's a revision batch going on and it has already started. Please try to enroll yourself. And if you want to have a free access for the special classes, please use the code Dr. Dixit. Dr. Dixit to access the classes for free. Thanking you, and I'm signing off. Stay safe, and I hope you enjoyed. Do give your feedbacks on the platform.